Sorry for the delay, sir.
No problem. Am I audible?
Yes, sir.
Yes, sir.
Yes, sir.
Okay.
Can we start, sir?
We'll go ahead.
Yes, sir.
Professor, my dear students, I welcome you all to this another session of theory exam questions practice session. I will hand over the session to Professor. Invite Dr. Muthupriya to start with the presentation. Dr. Muthupriya?
Yes, sir.
Actually, the students wanted a discussion on blood transfusion. Some of the topics they wanted included blood transfusion as one among the theory question discussion.
Yes,
So
sir.
when I went through the whole question bank, I found these three topics have been repeatedly asked. One is the changes that occur in the stored blood, whole blood. Then the second one is the blood components and their uses. The third one is massive transfusion and massive transfusion protocol. So I have given all the three questions as A, B, C. Priya will be presenting the first and third.
Yes.
We will be presenting the changes that are occurring in the whole blood as well as the massive transfusion protocol. Okay, so go ahead, Priya.
Yes, sir. Good evening, everyone. Today my topic is blood. So the unit of blood which is collected from the donors are usually separated into components like PRBC, plasma, FFP, cryo, platelets. These blood are stored with anticoagulants to have a longer shelf life. So the preservative use is mainly about CPAD. It is stored at a temperature of 1 to 6 degrees Celsius, which includes, it contains citrate, phosphorus, dextrose, and adenine. The citrate is used to prevent clotting by binding it to calcium. And phosphorus, it serves as a buffer. Dextrose, it is a red cell energy source, which increases the ATP by anaerobic glycolysis. And adenine 1, which is used to increase the RBC survival by resynthesis of ATP. So one unit of blood contains 3 grams of citrate, and normally about 450 ml of blood is collected and 60 ml of preservative is added to the blood to make it have a longer shelf life. Normally it can be used about 21 to 35 days, but by adding Adsol, Nutricel, and Opticel, it can be increased up to 42 to 49 days. The hematocrit of the transfused blood depends on the storage method. In CPDA, there is a hematocrit of about 65%, and most of the plasma is removed. So the volume is about 250 ml. And in AS1, that is Adsol, it contains adenine, glucose, mannitol, and sodium chloride, which has a half-life of about 49 days, and it has a hematocrit about 55 to 60%. Most of the plasma is removed, but 100 ml of storage solution is added, resulting in a volume of about 310 ml. In ASD, that is acid citrate dextrose, it has a storage time of about 21 days, and frozen storage, that is glycerol, is added as an antifreeze, and it can be stored about up to 3 to 5 years. Coming to the changes, these are known as red cell storage lesions. During storage, there is a series of cellular and biochemical reactions that occur, which alter the biochemical makeup of the cell and occurs in and may result in some complication, which is responsible for organ injury. Now, during storage, the RBCs in the blood undergo glycolysis and to form lactate. Here, the H plus lactic acid accumulate and result in acidosis. This acidosis can cause oxidative damage to the lipids and proteins. And at a temperature of 1 to 6 degrees Celsius, there is an inactivation of the sodium and potassium pump, which leads to the leakage of potassium from the cell into the plasma, resulting in hyperkalemia. Over time, the ATP and the that is depletion of 2,3-diphosphoglycerate, which shift the ODC curve to the left, and that is decrease in oxygen affinity to the tissue. So it's bind more to the hemoglobin, and there is increased osmotic fragility of the RBC, leading to hemolysis and increase in free plasma hemoglobin, which lead to radical injury, and increase impairment of deformity of the RBC, resulting in microocclusive events, that is defective oxygen delivery. And there is decrease in calcium. As the citrate binds to the calcium, it can lead to hypocalcemia. The platelets get inactivated by the cold storage, and there is a increase in microaggregate, increase in PaCO2 due to the old blood, and there is a gradual loss of membrane integrity is seen. The red cells in the stored blood can be regenerated with a solution of ionazole prior to administration, which is called as reverse storage lesions. Coming to massive blood transfusion protocol definition, massive blood transfusion involves replacement of one circulating blood volume in 24 hours, or replacement of 50% of circulating blood volume in 3 hours, or transfusion of 4 units of blood in 1 hour, or transfusion of 1 unit within 5 minutes. So prior to blood transfusion, we should adequately screen the patients for screen the donors for look out for any infections, and we should prepare the patient with 2 large IV cannula, triple lumen catheter, IV catheter for rapid blood sampling and measurement of CVP, 3-way cannula, wear gloves to prevent contamination, Foley's catheter to measure urine output, core temperature monitoring to measure temperature, pulse oximeter, rotem or TEG to measure the coagulation profile, ECG, arterial pressure, warming device, rapid infusion pump and pressure bags, adequate manpower and communication with the blood banks. So MTP is usually designed to interrupt the lethal triad like acidosis, hypothermia, and coagulopathy. It is mainly initiated to maintain the adequate blood pressure, adequate blood flow and arterial pressure to maintain the tissue oxygenation. So massive blood transfusion is usually done in trauma involving like liver, cardiac or vessel injury, or obstetric hemorrhage like PPH, coagulopathy during surgeries like cardiopulmonary bypass or major surgeries. So MTP is activated usually by a senior clinician in response to a massive bleeding. The baseline ECG, coagulation, ABG, and biochemistries are done. Here the MTP is activated. It has a predefined ratio of about RBC, FFP, and platelets in a ratio of 1:1 or 2:1:1 for transfusion, depending on the center. It is institutional, depending, and can vary from center to center. So massive bleeding is usually occur during elective surgery with unexpected or expected loss or medical obstetric casualty. So we have a transfusion goal to maintain adequate tissue perfusion, oxygenation, cardiac output, and metabolic state. We should restore the circulating blood volume and arrest the bleeding with surgical or radiological intervention, and maintain the hemoglobin above the minimum acceptable range for the adequate cardiopulmonary reserve. So we should contact the key personnel, that is the trauma team, hematologist, and blood bank personnel to facilitate communication between the different service and allows for easy administration, which allows which delays the time, which allows delay timing and communication. What are the coming to the hematological goals and minimum lab investigations? Minimum lab investigation like blood grouping, cross matching, potassium, ionized calcium, ABG, hemoglobin, PT-INR, APTT should be done. Avoid delay in lab testing and clinical care, nursing care, and blood transfusion. So, to the hematological goals, we shall have an aim for temperature above 35 degrees Celsius, pH 7.2, lactate more than 4 millimole per liter, calcium more than 1.1, platelets above 50,000, PT-INR less than 1.5 the normal times, fibrinogen more than 1 gram per liter, MAP about 60, and systolic BP about 80 to 100. We should maintain the hemoglobin about 9. So, if there is a massive blood transfusion, previously we gave crystalloids and colloid for massive blood transfusion, which leads to delay in recovery from the coagulation or coagulopathy or like the bleeding, that is ongoing bleed loss. So this lead to dilutional coagulopathy also. So coming to the components of MTP, we should know when and who initiate the MTP. We should notify the transfusion service and lab testing regarding the start and stop of MTP. Lab testing algorithms like CBC, PT-INR, fibrinogen, ABG, and TEG should be done. Blood product preparation and delivery should be done, and other patient care should be done. So, if there is an emergency on arrival and if there is a active ongoing blood, we can give uncross matched blood like O negative, which is a universal donor for PRBC, and FFP we can give AB positive blood group. So we should adequately evaluate the patient and retransfuse using pads according to the lab test. And if the patient attains the transfusion goals, then we should stop the NTP. Some of the other alternative strategies are recombinant factor 7A, prothrombin complex concentrate, fibrinogen concentrate, and antifibrinolytic agents like tranexamic acid, which is given like 1 gram over 10 minutes followed by infusion. Coming to the limitations, what are the limitations of massive transfusion protocol is the trigger for initiating the protocol as well as the optimum ratio for PRBC, FFP, and platelets, that is 1:1:1, varies from center to center. And if the MTP is triggered for a non-massive blood transfusion, it can lead to the wastage of blood products. Coming to the complications of massive transfusion, it can lead to a serious complication like immunological complications, Charlie-Charcot, and infections like bacterial HIV, HPSAG, HPD, HCD, to serious complications. Thank you, sir.
Is there any case waiting? You have to go for your duty, or you can stay for
No,
time?
sir.
Huh?
Oh, sir. I will present, sir. Complications still more to present,
What
sir.
I thought was I will ask Abhirami also to present, and then we can complete
Yes, sir.
this
Yes,
topic.
sir.
Can you wait
Yes,
till that time?
Yes, sir.
Okay. Abhirami,
Yes, sir.
you finish your portion also so that we can discuss the whole thing in one shot.
Yes, sir. Yes, sir. Yes, sir. My topic is blood and blood products. Blood is a specialized body fluid. Normally, blood is 8% of total body weight. The components include plasma, RBC, WBC, and platelet. In plasma, there will be water will be 91%, proteins 7%, and other solutes 2%. Then a process of blood separations. Initially, we should educate, recruit, and select proper donor. We should check test for HIV, HBsAg, HCV, HTLV, ABO, RH compatibility, and other red cell antibodies like malaria, HBs, and all. Then the whole blood is centrifuged to remove leukocytes. It gives PRBC and platelet-rich plasma. That PRB is stored at 4 degrees Celsius for 42 days. Then platelet on centrifugation give plasma and pooled platelet. This plasma on freezing at minus 30 degrees Celsius gives FFP, which can be stored up to 1 year. This pooled platelet stored at 20 up to 5 days. This plasma on thawing at minus 70 degrees Celsius, it also cryo. And the supernatant gives albumin, immunoglobulin, and other coagulation factors. Now, PRBC, it is obtained from WBC by removal of platelet-rich plasma by centrifugations. Composition: 200 ml of RBC, 50 like plasma will be less than 50 ml. Additives around 50 to 100 ml. Totally volume of 300 to 350 ml with a hematocrit of 55 to 60%. Storage: as Muthupriya ma'am told, the bag anticoagulative solutions are acid citrate dextrose up to 21 days. And citrate phosphate dextrose, the same 21 days. Citrate phosphate dextrose adenine up to 45 days. It is stored at 1 to 6 degrees Celsius and for transportation of for 1 to 10 degrees Celsius. The bag is made up of PVC. Indications: in case of anemia, indicated if hemoglobin is less than 7 gram per deciliters. In case of 7 to 9, the decision is taken based on cardiopulmonary risk factors, ongoing blood loss, and clinical judgments. And other indications like acute blood loss, more than 1500 ml in adults and or 40 ml per kg in children. Dosage: actually, in 1 unit of PRBC increases 1 gram per deciliter of hemoglobin and PCV of around 3%. It takes about 24 hours. Then typing and cross matching. ABO compatibility and RH compatibility and ABO compatibility. The screening of patients' plasma for antibody to donor RBCs. O negative is a universal donor. O positive can also be used. We should administration: look for any transfusion reaction. Administer over 1 to 2 hours, not more than 4 hours. Characteristics: Hematocrit will be around 55 to 60%. pH will be around 6.79, and bicarb 11 millimoles per liter, plasma potassium 20.5 millimoles per liter, and lactic acid of around 9.4 millimoles per liter. Disadvantages: if more than 2 weeks of storage, there'll be decrease in 2-3 dpg, and there'll be ODC shift towards the left. 50 to 20% of RBC are lost, so there'll be increased potassium concentration, elevated PCO2 and ammonia levels, and lowered pH. And now coming to platelets. Platelets are produced from whole blood by centrifugation or apheresis. Types: apheresis platelet, single donor platelet, platelet concentrate, platelet, pooled concentrate from 4 to 6 whole blood donations, increased risk of disease transmission and transfusion reactions. Lymphocyte depleted platelets, irradiated platelets, and cryopreserved platelets. Storage: it is stored at room temperature at 20 to 24 degrees Celsius at a constant agitation for 5 days. Then indications: stable patient without signs and symptoms, platelet less than 10,000, we can transfuse. In case of prophylaxis for CVP insertion, platelet less than 20,000. Prophylaxis for invasive procedures like biopsy, LP, neuraxial blockade, coagulopathy, less than 50,000. Stable patient with signs and symptoms less than 50,000, we should transfuse. Patient undergoing massive transfusion, the level should be around 75,000 to 1 lakh. All your neurosurgery, 80,000 to 1 lakh. Then dosage in children around 5 to 10 ml per kg, adult 1 unit of RDP or 10 kg per body weight, approximately 4 to 6 units of RDP, transfused over a period of 20 to 30 minutes. 1 unit of RDP increases the platelet count by about to 10,000 after 1 hour of transfusion. In case of single donor platelet, the platelet increase will be around 5,000. And indication like thrombotic thrombocytopenic purpura, heparin-induced thrombocytopenia, there will be a platelet activation and concept of coagulopathy. And ITP. Side effects: it is more commonly associated with infections, sepsis, febrile non-hemolytic transfusion reactions, TRALI, and anaphylaxis. Platelet refractoriness: poor increment 24 hours of transfusion in case of hypersplenism, fever, bleeding, and DIC and older platelets. In case of next fresh frozen plasma, it is produced by centrifugation from 1 unit of whole blood or apheresis. It is the most dangerous blood product. It contains all coagulation factors. That factor 5 and factor 8 have less T-half on prolonged storage. Types: it includes fresh frozen plasma, frozen minus 18 to 30 minus 30 degrees Celsius within 6 to 8 hours. Thawed plasma, thawed in water bath at 30 to 37 degrees Celsius, usable up to 5 days. Storage is same, like minus 20 to 24 degrees Celsius, fresh frozen plasma, used up to 1 year. Quantity, the volume is around 200 to 250 ml. Composition, it consists of fibrinogen, around 700 to 800 mg per liter, and all coagulation factors, protein C, protein S, albumin, antithrombin 3, and electrolytes, immunoglobulin, and complements. ABO compatibility ensured. RH incompatibility is not necessary if it does not contain RH antibody. Antibody screening prior to fractionation. Universal FFP donor is AB RH negative. Dosage: in case of congenital or acquired clotting factor deficiency, in case of pediatrics, 10 to 15 ml per kg, adult 15 to 30 ml per kg, or 4 units to achieve a more than 30% factor concentration. For reversal of warfarin therapy, 50 to 30 ml per kg of FFP is given. In case of massive blood transfusion, FFP is to PRBC 2:3 ratio is given. A rate in case of healthy, stable, the rate of infusion is around 2 to 3 ml per kg per hour. 1 unit of FFP increase factors by 5% and 2 units increases the factors by 10%. Indication: FFP is given in case of warfarin reversal, heparin resistance secondary to antithrombin 3 deficiencies, and correction of congenital and acquired factor deficiencies, liver dysfunction, helps in IC, massive blood transfusions, and exchange therapies and hereditary angioedemas. Side effects, side effects are trally, taco, and febrile allergic reactions, anaphylaxis, infections. Contraindicated, it is not sole purpose for volume replacement. It is not a reversible for heparin, direct thrombin inhibitor, and direct NA inhibitors. Next, cryoprecipitate. It is created by thawing of FFP at 4 degrees Celsius. Allow precipitations of large molecule. The supernatant or insoluble proteins are removed, and this cryo is suspended in 10 to 13 ml of plasma and refrozen at minus 18 degrees Celsius. Composition consists, the volume will be around 10 to 20 ml. Fibrinogen, fibronectin, 1 milliband factor, and factor 8. Storage, it is stored at minus 18 degrees Celsius, shelf life of 12 months. To infuse within 6 hours of thawing. Adult dose 5 to 6 cryo or 1 unit per 10 kg. It increases the fibrinogen level by 50 milligram per deciliter. Indications, microvascular bleeding with hypofibrinogenemia, DIC with fibrinogen less than 150 milligram per deciliter, hemorrhage or massive transfusion with fibrinogen, prophylaxis in hemophilia A and volume 1, and congenital dysfibrinogenemia. Cross-matching is usually not necessary. ABO compatibility is also not essential except for neonates and hematopoietic stem cell transplant and in case of small children. Infections, complications include infections, TACO if large volumes are transfused, and allergic reactions. Thrombocytopenic bleeding, reversal of warfarin therapy, isolated clotting factor deficiency other than factor 1, 8, and 13, and 1 milliband factor. Next, granulocyte. Granulocyte. Transfusion of granulocyte is indicated in severe sepsis. Because of contaminated red cells, granulocyte component must be ABO-RHD compatible with recipients. There are two granulocyte-rich components, Buffy-core derived from blood or granulocyte collected by apheresis. Other plasma derivatives includes albumin, immunoglobulin, and clotting factor concentrate. That's it.
Right. All the topics have been well covered by both of you.
Yes, sir.
But a few points you have to add to these answers is for Muthupriya, you have to say the changes that occur over a course of the time. From the date of collection, you said the maximum lifespan of whole blood which can be stored is for 42 days. So it is better that if you say what will happen on the first day, what will happen on the 18th day, what will happen on the 21st day. So they call the blood as young blood and old blood, isn't it? Have you read about that? What is the difference between an young blood and an old blood? Not the person's age from whom you collect. Is it storage life? Your mic is not on. Please unmute and talk.
Yes, sir. The pH potassium values will change gradually over a period of 21 days, sir. Okay.
So that is why in earlier days we were using whole blood. But the concept of components, how did it come into clinical practice? Why people have stopped using whole blood and why they have started using the components like PRBC, platelets, or FFP, cryo, etc. What is the reason for that?
Reactions.
Hirami, this question is to you because you have talked on the component.
Transfusion reactions.
Transfusion reaction, is that the first reason for that?
We can give specific in case of
To increase, to prevent DIC.
Yes. See, all patients do not require all the components of the blood. For example, if a patient is purely anemic and is not responding to oral iron therapy or erythropoietin therapy, and he is very symptomatic and he requires mainly hemoglobin to carry the oxygen in the body, then we give them blood transfusion with packed red blood cells, isn't it? So
Yes,
you
sir.
can separate the packed red blood cells and give it alone without the other components which are not required in that patient because the other values are quite normal. On the contrary, if a patient with a thrombocytopenic purpura where there is a deficiency of platelets mainly, then the possibility of giving him the platelets alone to replace where the hemoglobin is more than 12 or 15, it is not necessary to dump him with more RBCs and waste that RBC. Okay, so that is the reason why people thought they can separate the components of the blood, whole blood, and use it according to the need or indication which the patient is suffering from. How is it possible? Why, when they thought of giving the components alone, what advancements in the collecting equipments made it possible? What are all the equipments that are needed to separate the components? Centrifuge, yes. What type of centrifuge? We had centrifuge for a very long time. But what type of centrifuge advancement or improvement made it possible to separate them? Refrigerated centrifuge. Okay. So instead of just simply refrigerating at room temperature, there was an equipment called refrigerated centrifuge was invented, which is able to bring down the blood temperature of the whole blood within a few minutes to the required temperature of 4 to 6 degrees. Okay, and then when separation is also told, you must say about the spinning of the centrifuge to separate
Hard
the
and
components.
soft.
That is very important because one of the 2018 question, it had the components and how they are prepared. It's also part of the question. So during that time, you must say how many, whether it's a light spin or a heavy spin, or how many revolutions. Usually light spin is about 2000 G and heavy spin is about 5000 to 10,000 G.
Yes, sir.
The unit of spinning is called G. You know why it is called G? 2000 G and 5000 G. G for God. That is the unit that is given.
Okay,
What does that mean? Earlier it was revolutions per minute, RPM.
Yes,
But
sir.
now the unit of revolution or spinning is called 2000 G and 5000 G. Can you tell me what is the expansion for the G? Okay, you tell me before the end of the class. Okay, search for that and tell me.
Yes, sir.
Right. So that is another part you have to include in your answer. And the third thing is whether cross matching is required for all the components or not. Definitely for RBC you require
Yes.
cross matching. Without that you cannot give the RBCs because there will be antigen antibody reaction. What about platelets?
No need, sir.
No need.
Usually not necessary, but it is preferable to give ABO compatible platelets. Okay, but there is as you said, pooled platelets you collect from different people, and where it's a single donor platelet you get from the single patient. That will not be a problem. But in pooled platelets, sometimes you can get a reaction. So preferably, if you have the same group patient donating platelet, you can, that will be more safer than pooled platelets where you take it from multiple sources. And for FFP, definitely you need compatibility. Okay, that is another point you have to insist on. And of course, the cryo and the lesser components, they don't require the compatibility test. That also has to be mentioned.
Yes,
And
sir.
how they are stored and what are their compositions, all that you have mentioned, and that also to be highlighted in your answer.
Yes, sir.
And with regard to your massive transfusion protocol, it is better that you start with the first definition, then immediately you mention about the indication where you will be using it.
Okay, sir.
In your short training period, have you ever come across a case where you have given more than the total blood volume in 24 hours in any cases?
In
Liver
a
transplant, sir.
case, liver transplant case, sir.
Liver transplantation. That's the reason I asked you, because in your center you are doing liver transplantation. There's an opportunity that you would have seen a case of massive blood transfusion, which is common in liver transplant centers where there will be heavy bleeding and you have to follow all the problems of massive transfusion, how to do that, what is the protocol. The second important thing is all centers dealing with trauma, they also will come across, for example, massive vascular injury, aortic injury, or a splenic injury, or a liver tear with multiple fractures. These patients come in a very exsanguinated state where they require massive transfusion to resuscitate them to restore their blood volume. So in this situation, you must always mention about the classes or grades of hemorrhage. Class 1, class 2, class 3, class 4. And massive transfusion is usually beyond 30% of loss of blood volume. That is where you initiate massive transfusion protocol. And initially, whenever you anticipate or you see a patient with a heavy bleeding, a hemorrhagic shock, it is always better to replace the loss with blood itself instead of trying to resuscitate them with crystalloids or colloids, which will further dilute the coagulation factors. It is better to resuscitate them with 1 to 4 units of compatible or emergency. You can go for O negative blood. And beyond 4 units, if the patient is not becoming hemodynamically stable, that is the time you must activate the MTP protocol. Okay, so you can, and MTP is a multidisciplinary approach. It's not done by a single clinician or anesthetist alone. So you have to have the cooperation of the physician, intensivist, surgeon, and anesthetist, and blood bank people, and even the paramedical people to take the samples to the lab in case if it is done not at bedside. So it's a teamwork to be done, and most of the hospitals have their own protocol, and ready packs are available in massive transfusion. If you order for, if you give a announcement that we are initiating MTP, that is massive transfusion protocol, just like a code blue in a hospital, immediately the blood bank will be alerted so that they will be sending a continuous supply until you say stop, we have resuscitated the patient or patient has not made it. Any one of the instructions still that is given, the blood will be continuously given to the place where you are resuscitating the patient. Okay, so that is the idea of doing it in a large scale, and such requirements will come in massive calamity also. There is a major train accident or a building collapse where you get people with massive trauma. That is also another indication where you get. And the common simple indication is postpartum hemorrhage. At one time or other of your practice, you will be coming across such patients where suddenly, unexpectedly, patient will not stop bleeding after delivery. Either it may be a cesarean delivery or a normal vaginal delivery. But after that, patient does not stop bleeding, and the postpartum hemorrhage happens. And that is another very unexpected and confusing clinical scene where you will be initially trying to resuscitate the patient with steroids and colloids because the blood will be gradually getting lost, and that is another indication for massive transfusion. Okay, so after definition, it's better to say what are all the indications like trauma, major surgery, orthotic and postpartum hemorrhage, like that, and then go into the methods for how you start the massive transfusion, for which you require a good IV access, like a wide bore IV cannula, either peripherally or centrally situated. And in rare cases, you have to mention about intraosseous also, especially in pediatric massive transfusion, where IV access may not be probable, still you can do it by intraosseous route also. So that also can be mentioned. And then the rapid infusion systems and the pressure bags and all those equipments first you have to describe. Warmers, inline as well as surface warmers, because hypothermia, acidosis, coagulopathy, as you said, are the triad of massive transfusion complications. So that has to be prevented, and you have to do all the monitoring, right, from intra-arterial blood monitoring to CVP monitoring, and then regular ECG and periodic electrolytes, ABG, and core temperature monitoring. All these things also will play a major role in maintaining the normal value of the patient in massive transfusion. And finally, you must say about the other complications like volume overload, over resuscitation or under resuscitation, and then biochemical changes and immediate and late. That is the way you can classify the complications. And finally, you must say what is the end point of this massive transfusion? What is your goal? What you have to achieve? The ultimate aim is the hemodynamic stabilization of the patient. What should be the pulse rate? What should be the mean BP? What is the hematocrit or hemoglobin that you want? What is the pH and the ABP values that you want? What is the temperature of the patient? So all these things will be the end, the aim or the goal of MTP. So this is the overall